Thanks very much. At the outset, I would like to express my gratitude to Dr. Khanna for inviting me yet again to the APVIC-IV, I think this time, and look forward to being part of this out here. And my earlier speaker, Rahul, has already, I think, made my job much easier by elaborating on the management, or rather the investigations for endoleaks. So without much ado, I'll just get on to the main thing. It's a term that describes the presence of persistent flow of blood into the aneurysm sac after a device placement. And this is the main complication of EVAR, which we look to and address it at the same time if possible. And this is one of the prominent causes for re-intervention also in aortic aneurysms. There are basically 5 types of endoleaks which are there, to which I'll elaborate further. And all types of endoleaks can potentially increase the risk of delayed rupture and or the chance of a surgical conversion. So it's very important that once you finish a procedure, doing an EVAR and all sounds very simple. Sometimes you finish the procedure in 45 minutes or maybe even less time sometimes. But at the end of it, the most important thing is that you must follow up your patients with regular follow-up CT angios or whatever investigations you want to use. Because otherwise you may suddenly have a great procedure, but at the end of it, 1 year or something like that, suddenly the patient dies of complications which are eminently preventable. Endoleaks on post-procedure surveillance imaging are present acutely in 30 to 40% of the patients. So a fairly high percentage of patients will have endoleaks. And follow-up of these patients, 20 to 40% of these cases may have something. The only question is, when do we really tackle them? Endoleaks are termed early if they're present within the 30 days and late when they're present after that. So here, as in this particular picture, you can make out, these are the various types of endoleaks. Where you have a problem with the proximal part of the neck, you have a type 1A endoleak out here. Then you have a type 1B, which is at the distal end where you've done your distal sealing. If the sealing is inadequate, then you have a type 1B endoleak. These are the ones which need to be addressed either immediately on table, or they should be done in the immediate postoperatively period, preferably within 1 week's time. Then you have the ones which are relatively, I'm saying relatively innocuous, which are the type 2 endoleaks, because there will always be some vessels which will be feeding the sac, which are the lumbar vessels, the inferior mesenteric artery in the abdominal aorta, and other things which can produce these kind of endoleaks. Most of them tend to resolve within about 6 months. Then you have a type 3, which can be a device failure. Sometimes you have major issues sometimes with the devices. I'll show you some of the pictures. And then you have a type 4 fabric porosity, which is there. All grafts tend to bleed a little bit or ooze a little bit. They become a little wet. Dacron grafts also have the same problem, even PTFE also. So you see a gentle blush of contrast sometimes. That's a type 4, which generally resolves within the next few hours. And then, of course, there's one problem, conundrum, which is there is the endotension, where you really can't pick up where the cause of the leak is, but the sac keeps on increasing in size. So a type 1 endoleak, which occurs in almost 0 to 10% of endovascular aortic aneurysm, is due to an incompetent seal at either the proximal or a distal part, which is there. And the various reasons are basically, one is improper sizing of the device. You undersize the device, you may have a problem. Sometimes you oversize the device too much, and when you do a balloon dilatation, the device just slips down. So these are certain things which can be there, and they should be repaired as soon as possible, because they can be a major cause for morbidity and mortality after a period of time. Small type 1A endoleaks, sometimes you have basically a very tortuous anatomy. You have a lot of calcium and all in the vessels. You can observe them for a period of maybe 1 month or 6 months, but then you should be closely following up the patient to see that there is no increase in the sac size or the volume of the sac which is there. And if it's still present at 6 months, then in that case, you should basically consider tackling them. Many early ruptures, in fact, were initially linked to the type 1B endoleaks, which were seen with the first generation tube grafts. Now, of course, you have much better devices and all. You have the bell bottoms which have come in and the various other kinds of devices where you land them nicely and properly, you fix them properly. So things are definitely on the lesser side with the type 1B endoleaks. But wherever they are, they tend to go retrograde and increase the sac size. So just to show you some of the procedures which can happen, you have this patient who had a tortuous anatomy. You can see the amount of calcium in the neck which is there. And subsequently, we did a EVAR for this particular patient, developed a type 1A endoleak at 6 months, because the aorta, the moment, once you put in an endograft, the aorta tends to change its conformability. As a result of that, the device tends to move a little bit out of position. And then, of course, you can have issues like this. You can have an endoleak out here. And then What we did in this particular patient was basically put in an aortic extender, and subsequently with that one, after this follow-up patient, this endoleak resolved. So type 1A endoleak, starting from the proximal part, angulated neck, putting in an aortic extension work basically in those situations. These are another type of patients where you have major issues. A lot of times, the moment you say that you have more than 60% angulation, the companies don't really recommend. So it's an off-label use of the device. And when you use endovascular stents in these ones, you have to follow up these patients closely to see that these devices stay in this kind of a position. You've done an endovascular stenting in this patient with almost 90-degree angulation, but you must see that you have good stability of these ones. So when you have these kind of aorta, where you have a lot of tortuosity, multiple sacral aneurysms, again you may have endoleaks out here. Again, another patient with this kind of a problem. The major problem, like the last case which I showed, is basically that once we finished the procedure, we found that there was a retrograde type 1B endoleak because his iliac arteries were filling up. Rather, the internal iliac was basically going and feeding into the aneurysm. There's so much of tortuosity that we could not put in a coil into that side. So eventually what we did was we made an extension of the incision from the groin and went in and ligated the internal iliac artery by doing an open method out there. Only it didn't really involve too much of work, but that was the best way of addressing the endoleak. Another patient with tortuous anatomy out here, these kind of patients where you have these kind of iliac artery aneurysms. Very important in these kind of patients that when you have extensions into the iliac arteries going into the external iliac and all, you must be able to use some branch devices or maybe be prepared to cover up with various kinds of, maybe cover up both the internal iliacs at some stages also. There's another one of those kind of patients. So I'll just move to these ones. Another patient where we had a type 1B endoleak out here down below and repeated balloon dilatation. And there was a persistence of the endoleak, and eventually what we had to do was keep on putting in extenders on both the sides. We had to cover up both the internal iliacs in this particular patient, and that was the only way to resolve this particular thing. So as you can see, this is now filling up. There's no filling up of the sac out here. This is another patient where we had multiple. This is a patient who had undergone TVAR and then subsequently developed this huge Clapper bell aneurysm subsequently. And of course, this patient was subjected to a hybrid surgery where we did a debranching of the abdominal aorta, and then after that we covered up the procedure. Another patient with the aneurysm of the aorta, which was basically around the visceral vessels. We did a debranching for this lady, did an endovascular repair. This is of course the debranching of the vessels which has been done. And secondly, subsequently when we evaluated her, this was the final picture on completion once we did the EVAR out here. Then what happens after when she comes up for follow-up, she develops this bubble out here on the proximal part. So again, we had to put in another device in this particular patient to cover it up. Another patient with tortuous anatomy where there are lots of things. Then going on to the type 2 endoleaks, which are the most prevalent type, they occur in 10 to 25% of the patient because of the branch vessels. So the timing of the contrast injection during the CT will determine whether a type 2 endoleak is visible or not. So you must take some element of delayed shoots also to see whether the retrograde filling of the sac takes place. Once you have these ones, then in that case, most of the investigators, a lot of controversies on that one, but a lot of people tend to wait, and we also tend to see the wait and see approach, and most of the time these type 2 endoleaks tend to resolve over a period of time. You need not do anything unless and until they cause a major problem. This is another one of a patient with a type B dissection in the infrarenal aorta, and you can see an endoleak out here from the lumbar vessel out here. Another picture of the same patient. As you can see, this kind of an endoleak, sometimes you have a florid kind of an endoleak out there. And of course, putting in grafts on both the sides, eventually this patient settled down. So just showing you some pictures of these ones. Then going on to the type 3, basically where there's a disjunction between the modular component or a hole in the fabric of the graft. This is a problem sometimes which can happen. And this occurs early after treatment. Sometimes a wire or something of the sort basically perforates the fabric of the graft when you're doing a secondary procedure, and you can have these kind of problems. And the management is basically very graft specific, and the only thing is to cover it up with another graft. They should be repaired as soon as possible. Another patient who's had a TVAR done came up for follow-up, and as you can see out here, there's only a small spine of the stent visible out here. and this graft is opened up out here, and eventually we had to go in and put in another device and cover this whole thing. Type 4, as I mentioned, is due to the porosity of the graft fabric, and you don't really need to do anything much for these kind of patients. So just going on to the type 5, which is the endotension, that is what I said is a conundrum where you don't really have an identifiable source of endoleak, but the sac continues to expand. This is something that we even see in open surgery at times. You do an endoaneurysmography and the sac keeps on exuding certain material out there, and the sac keeps on getting pressurized. So sometimes you may have to open up this or maybe inject something into this particular thing. So to conclude, the endoleaks are an inherent risk for EVAR and TVAR, and post-operative surveillance is the most important thing. And you must basically carry out 1 monthly followed by 6 monthly. We have a regimen in our hospital where we do these patients, they are subjected to an endoaneurysmography, and we do them one month CT angios, then 6 months. Once a year, every year, they must come basically for follow-up. And in cases where you have a type 1A endoleak or a type 1B, we do a CT angio after 1 week and then decide accordingly. And probably the newer devices are likely to reduce such complications. Thank you very much.